Hello, my name is Jeff Johnson. I am a partner and CPA with Wipfli LLP, a CPA and consulting firm. Our national healthcare practice provides services to hospitals, health systems, senior living facilities, and medical practices by providing innovative solutions to demanding healthcare issues. I am based in our Spokane, Washington office and have more than 20 years experience working with hospitals and physician practices, including critical access hospitals, rural health clinics, and FQHCs, or federally qualified health centers. Thank you for taking out time today to listen to this 15-minute session or so on the basics of cost-based reimbursement. As you can probably imagine, we cannot begin to cover everything in 15 minutes, but perhaps we can at least provide you with a good overview that, if needed, you can reach out to your current cost report preparer or me for further questions or discussion. Our purpose today is to provide you with an understanding of the differences between how hospitals get reimbursed by Medicare, understand how critical access hospitals get paid, and understand the impact of cost-based reimbursement on financial reporting. Although critical access hospitals receive cost reimbursement, the methodology of computing cost reimbursement is different depending on the service provided in the critical access hospital. Acute inpatient services are reimbursed on a cost per day basis, which is the sum of the routine cost plus the ancillary services provided while an inpatient in the hospital. Swing bed services are computed exactly the same way as routine or inpatient services. The difference between inpatient and swing bed cost per day is the amount of ancillary services provided. Acute inpatient rates are generally much higher due to the more ancillary services being provided, such as lab, X-ray, and other diagnostic services, versus swing bed, which may only include therapy type services. Outpatient services are also paid based on cost for critical access hospitals. However, the calculation of those costs are based on what is referred to as the ratio of cost to charges, or often referred to as the RCC. This ratio is determined by dividing the overall allowable cost by the overall gross hospital charges by department. Interim per diem rates for inpatient and the ratio of cost to charges are based on your last as-filed cost report or an interim cost report that may be requested by the Medicare administrative contractor, also known as the fiscal intermediary. A temporary settlement is based on the as-filed cost report submitted after the fiscal year end, with a final audited settlement generally 1 to 2 years following the submission of the cost report data when audited by the Medicare administrative contractor. It's important to note that there are several services provided at critical access hospitals that are not cost-based reimbursed. I've identified several items on the slide that are typically part of a critical access hospital. Another item that is cost reimbursed that may be included as a service line operated by critical access hospitals are rural health clinics. There are special requirements to operate rural health clinics. Many critical access hospitals operate rural health clinics if they have primary care providers. Their costs are reimbursed based on an all-inclusive cost per encounter. The next 3 slides are intended to provide an illustration of the differences in reimbursement of hospitals paid on a prospective payment system methodology versus critical access hospitals that are paid based on a cost-based payment system. Keep in mind that although the critical access hospital program has a variety of conditions of participation that qualify it to be a critical access hospital, most critical access hospitals operate just like smaller community PPS hospitals. It's just that they either now or at some point in the past, qualify for a critical access hospital designation through the FLEX program as enacted under the Balanced Budget Act of 1997. Many critical access hospitals not only provide routine inpatient care and basic outpatient care, but several provide general surgery services, orthopedic, and other specialty care. The critical access hospital benefit is that they receive cost reimbursement instead of prospective payment reimbursement, which helps critical access hospitals overcome the shortfall in volume that would be needed for them to be viable in the PPS environment, like their urban hospital counterparts. As you can see on the slide, nearly all the basic services provided by critical access hospitals are cost reimbursed, compared to those hospitals that are PPS reimbursed or prospective payment system reimbursed under either DRGs, diagnostic related groups, or APCs, ambulatory payment classifications, which are all prospective payment systems. One item to point out on this slide is the critical access hospitals have the option to choose the standard method or method 2 when billing for outpatient services when the critical access hospital also employs or bills on behalf of the physician or a non-physician practitioner providing the service. Method 2, which allows for an additional benefit, added benefit to Medicare beneficiaries. The standard method is the default and includes a separate bill from the hospital plus a separate bill for the professional services. In other words, you receive cost reimbursement from Medicare for the hospital or facility services, and you receive Medicare fee schedule reimbursement for the professional service. Think of ER, the emergency room. The patient will get a bill for the hospital services or the ER services provided in the hospital, the nursing care, the ancillary services, etc. But then the physician may also bill for the professional service separately. Method 2 allows the hospital to combine the facility component or the hospital component and the professional component on the same claim form. The facility component is reimbursed just like under the standard method or cost reimbursed. However, for the professional component, the hospital will receive fee schedule reimbursement from the Medicare administrative contractor, plus an additional 15% payment from Medicare. Hospitals must make the election to bill under Method 2 30 days prior to the end of the fiscal year they wish to begin billing under Method 2. Again, Method 2 is only applicable to outpatient hospital services where you have physician services also being provided. So it could apply in the OR as well, but it does not apply to rural health clinics, nor does it apply to inpatient or swing bed services. The remainder of the differences relate to some add-on type things that PPS hospitals receive that critical access hospitals do not. Critical access hospitals are already receiving cost reimbursement, so logically there would not be any add-on for these types of services. I do want to point out two items on the slide. The first one is the 72-hour rule does not apply to critical access hospitals. I repeat, it does not apply to critical access hospitals, the 72-hour rule. Also, critical access hospitals, although they're limited to 25 acute or swing bed combination of beds, 25 beds, they can also have other sub-providers with a maximum of 10 beds, such as a rehab unit or a mental health unit. Both of these programs are reimbursed based on a PPS methodology. I also want to just point out that sequestration is in effect reducing Medicare payments by 2%. So, which in effect is reducing your cost reimbursement from 101% down to roughly 99%. Today we are talking about Medicare. However, many state programs follow Medicare. So we're not really talking about Medicaid, but again, some may also follow Medicare. Some follow Medicare for inpatient, some follow Medicare for outpatient, and some follow Medicare for both inpatient and outpatient. The cost report form is used by the Center for Medicare and Medicaid Services to determine the Medicare allowable cost for providing services to Medicare beneficiaries. Note that even PPS hospitals are still required to file a cost report, although there is relatively little immediate impact unless there are disproportionate share hospitals or hospitals participating in teaching programs. CMS does use these cost reports for setting payment policy for hospitals that are paid under PPS in future years. The cost report is due 5 months after the hospital's fiscal year end. Interim reimbursement is not the same as final reimbursement. Just want to point that out. However, they are computed the same. So your interim reimbursement rates may be different than your final reimbursement rate, and we'll talk a little bit more about that in the following slides. I'm not going to go through this slide. It's pretty busy. However, I just want to point out that hospitals are complex operations, and it's important to make sure you understand the various reimbursement methods and how to optimize the organization's payment from Medicare, Medicaid, and other third-party payers. When you're talking about cost reimbursement, CMS wants to make sure that you are only including what's reasonable. So what is cost? More specifically, what is allowable cost as it relates to Medicare? Medicare defines cost as necessary and proper for providing patient care. As part of that, Medicare also wants to make sure you are being prudent with your purchasing decisions. For example, most critical access hospitals contract with ER physicians through a purchasing contract or professional services agreement. Medicare wants assurances that you were prudent in your purchasing decision. This might be documented by receiving bids for those services or any larger material type purchases, whether it's ER physician contracts or purchasing of equipment and so forth, or EHR systems for that matter. Although Medicare pays you cost, you're not receiving full cost for everything provided by the hospital. Adjustments are made on the cost report which reduce costs, such as non-Medicare bad debt, advertising, reduction of cafeteria costs based on revenues received, investment income if you have not established a funded depreciation account, etc. The cost report is generally set up into sections. Overhead, patient care, which includes routine and ancillary, other reimbursable cost centers, and then non-allowable cost centers. Overhead costs include those items identified on the slide: capital, employee benefits, administration, and so forth. These costs are allocated or stepped down to various revenue-producing patient care cost centers, other reimbursement cost centers, and non-allowable cost centers to determine the fully allocated cost of providing these services. Patient care centers, patient care cost centers or revenue producing departments include patient care centers listed here. Again, as I previously stated, the overhead cost is allocated to these patient care centers to determine the fully allocated cost of providing services by department or patient care cost center. I'll use department and patient care cost center interchangeably. To arrive at the routine cost per day for adults and peds, these fully allocated costs are divided by the total inpatient acute care days to determine the routine cost per day. For the ancillary services in a hospital patient care area, such as OR, lab, x-ray, etc., the fully allocated costs of these departments are matched up with the hospital's gross charges for these services. The costs are divided by the charges, are computed to determine the ratio of cost to charges for each patient care department. The ratio of cost to charges is ultimately ultimately applied to the Medicare charges to determine the Medicare cost of providing services to Medicare patients. For the inpatient interim rate paid by Medicare, the inpatient ancillary Medicare costs are added to the routine cost per day to arrive at the overall inpatient interim rate used by the MAC for interim reimbursement on a claim-by-claim basis. The outpatient interim rate is based on an overall average of the outpatient patient care department's cost to department's charge ratio. The MAC pays, or the Medicare Administrative Contractor pays the hospital by applying this average ratio of cost of charges to the claim charges. So even though each department may have its own ratio of cost of charges, for interim payment purposes, those ancillary service departments are all added together and an average cost of charge ratio is calculated and applied to those Medicare charges on a claim-by-claim basis. For financial reporting purposes, the cost of operations, the census, admissions and discharges, and the ancillary volume and charges can vary from one year to the next. Hospitals really need to be proactive and avoid these surprises by monitoring their costs and their charges in their cost report on a regular basis. For this reason, it's important to monitor your census and overall ambulatory volumes on a regular basis and tie it into your overall monthly financial reporting. Smaller facilities tend to have more flux as they are generally Medicare dependent. Therefore, their settlement or the amount you owe or will receive on the filed cost report will be more dynamic, change more greatly. Large facilities tend to be more static from a materiality standpoint. For example, if you have a low census year last year and your current census and volumes are well ahead of the prior year, then it's likely you will have a payable to Medicare upon an interim cost report review or at the end of the year when you file the cost report. This is because you were being paid at a rate that was based on a previous year. If your costs stay relatively the same as the last year, but your volumes, both days and charges, increase, that will lower your current year rate, resulting in a payback or settlement in the current year due to the difference in your old rate versus the new rate that will likely be lower. Therefore, we typically recommend that critical access hospitals prepare interim Medicare cost reports at least 3 to 4 times throughout the year, depending on how much flux your entity has in volume. The MAC will typically ask for an interim rate determination at least once during the year, and it's generally during the last quarter of your fiscal year. Finally, the following are some additional resources regarding specific critical access hospital reimbursement information. I have also included in the appendix of this presentation a list of cost report and reimbursement acronyms used in this presentation and within the healthcare industry in general. Please reach out to the National Rural Health Resource Center or WIFLE if you are interested in learning more about these various resources or have questions on furthering your knowledge about critical access hospitals. I want to thank you for allowing me to share this brief time with you to learn about cost-based reimbursement for critical